Good morning, everyone from Indiana University in the US, and also good evening, the audience from Thailand. So this is a new course series that IAOC hosting with the Indiana University in the theme of learning with IU. And we choose the topic of the pediatric neuroradiologist for this academic year. My name is Tanya Supakul. I am a program director of neuroradiology program at Indiana University. And I am also the director of IAOC. So welcome everyone for these lectures. You can see from the intro video that we have a long relationship between Indiana University and also IAOC. We have done a couple courses in Thailand about pediatric neuroradiologists, having the attendings or staff from Indiana went to Thailand doing the lectures, and we got a lot of good feedback from the audience, not only Thailand and also the neighborhood country. We started this relationship since 2017, and we have it continues until this year. After COVID, it's still difficult, a little bit difficult for us to travel, but we want to continue these collaborations and share the knowledge from Indiana and show the world, show the people across the country, across the world to see how good we are as a team at Indiana University and IU radiologists. So today I am going to be the first speaker to giving a talk on the pediatric neuroradiology 101. I have Dr. Namphon to be Asani from Thailand IAOC as a co-moderator today. So she's going to help us on the questions and answer on the chat box, and also the questions and answer that going to have on the Facebook and YouTube Live. So let me share my screen here for you to see.
Yeah, this is Robin Hibbert. Can I ask a quick question for the pediatricians? What is IAOC?
Is like some educational center with the collaboration. The name comes from Imaging Academic Outreach Center.
Oh, cool. Okay, thank you.
And this is like the educational center in Thailand under the supervision of the Jurapur Royal Academy, which is like the medical center in Thailand that help under supervision of the princess and royal family. So this is like the educational center with the aim to provide a self-sustainable education and affordable education for the Thailand and neighborhood country. So the aim with this collaboration is we want to bring IU to the world, to share people in the overseas to see how good we are, and we also want to share the knowledge that we have built here at IU to people. So it's not only for the people across the world, but also like any trainee or any hospital, whoever want to come to IU to learn from us can watch and can see how good we are here on the lectures. That is the aim.
Excellent, thank you.
Sure. Oh, let me share my screen here. You see my screen now?
Yes.
Yes, okay. So let's start with so this is a talk on the pediatric neuroradiology 101. I will give you the overview on how to read the pediatric neuroimaging. So first of all, this is we have the CME code for this lecture. It's like a 2-hour lecture. So there are two codes, 74511 and 74512 for the people at IU to get the CME credit. But for the people overseas, if you want to get the CME credit, and you already registered to this course, you will get the evaluation form at the end. Please complete the evaluation form and then you will get the CME credit. I have nothing to disclose. So I would like to start with 2 questions. First of all, I want the audience on the Zoom meeting and also the audience from the Facebook and YouTube Live. Can you type the answer in the chat box? If you can pick one on the imaging sequence on the MRI brain, what is your favorite MRI sequence? It seems like axial flare is the most popular one here at IU. So Namphon, what is the most popular answers from the overseas audience?
No answer right now. Just start live now.
Okay, yes, that's okay. And we can go to the Next question. So based on your favorite sequence, some of you choose like an axial flare, some of you choose the axial T2. So how many diagnoses can you make based on your favorite sequence? How many diagnoses or disease if you choose axial flare, if you choose DWI, or if you choose the T2 or sagittal T1? So that is a good answer. It depends. It depends on like what do you see, right? And how you can combine with the clinical history and things. So for me, my favorite sequence to start with is sagittal T1. And I think today I am going to show you. I will give you like a 30 diagnosis based on the sagittal T1 only. So that is the number that I can come up. I will show you the 6 steps imaging checklist and review anatomy, basic embryology development on the sagittal T1 of the brain and highlight 30 pathologies based on the imaging findings. For imaging checklist on the sagittal T1, I would start from the midline cut of the sagittal T1. And then there are 6 things that you can see here first. It is at the foramen magnum when you draw the line between tip of the crevasse to the occipital condyle. The second anatomy that I am going to check is the midbrain, pons, and amygdala. The next one is the posterior fossa. The third one is the anterior and posterior pituitary gland, pituitary stalk, and hypothalamus. And then I am going to check at the tectum and the pineal region. And the last one is the corpus callosum. So for the foramen magnum, you draw the line between the tip of the crevasse and occipital condyle that we call Basion or Pision line. And then you put your cursor in that line. Let's look on these images. I have the sagittal images and also coronal for you to correlate. We draw the line, we put the cursor over there, and then we move the images, go right or go left to see if there is any low lying of the cerebellar tonsils below that line, to call any abnormal, like for Chiari-1 malformation, that low lying of the cerebellar tonsils more than 5 millimeters and also have the peg-like appearance. And you can confirm that findings on the sagittal image, on the coronal images, that you can see low lying of the right cerebellar tonsils more than left cerebellar tonsils. So look on this patient. So this is the patient come with a headache. You draw the line. First thing that you can see here is there is peg-like appearance with low lying of the cerebellar tonsils and cause mass effect and obstruction at the craniocervical junction. Compared to this patient, it may be a little bit difficult. If you don't pay attention by drawing the lines, you're going to miss that findings. When you draw the line and you go left and right, you can see that also the peg-like appearance and low lying of the cerebellar tonsils. And this one more than 5 millimeters. So this is a Chiari-1 malformation that can cause syringohydromyelia. And when you do the scan check, you need to teach your technologists to look on the images. And when they see this thing, you can ask them to add a CSF flow study to see any obstruction or decrease CSF flow in that location. The next one is the area that we call midbrain, pons, and amygdala. So there is a couple anatomy that I want to point it to you. This is anatomy that is very important for us. Whoever trained at IU radiology need to know this structure that we call obex. Obex is the opening of the central spinal canal. So, and this is a passcode for neuroradiology. If you train with us, you need to know obex from Dr. Wu. So on this one, when you identify the obex, you can draw 3 lines. The first one from the tip of the, at the lower border of the tectum, go anteriorly to the interpeduncular cistern. The second line is the line that parallel to the first one at the inferior border of the pons. And the third line is the one that passed to the obex. So by this way, you can have the midbrain, pons, and amygdala. And then you can see the ratio. Normally, in normal development, the ratio for the height for the midbrain, pons, and medulla should be 1 to 1. Or if you want to go really precise, it can be 1 to 1.8 or 2 and 1. So the pons should be bigger than midbrain and medulla. And when you look on this sagittal image, it looks like a bird with a big belly. So this is a good image for you to see the anatomy of the midbrain, pons, and medulla. Check on the sagittal T1 image. First one is pontomesencephalic sulcus and also bulbopontine sulcus. And then you should see the CSF space over there between the interpeduncular perimesencephalic cistern. You should see the CSF in the prepontine cistern and also the CSF on the suprasellar cistern. So look on this patient. First thing, you draw the line at the foramen magnum. There is maybe some crowding or maybe low lying of the cerebellar tonsils, right? And then you check at the prepontine cistern. There is effacement of the CSF space in the prepontine cistern, and maybe the anterior border of the pons looks maybe flattening. And then when you check on the stellar area, you can see a little bit juicy of the anterior pituitary glands. And then you lost the CSF in the suprasellar cistern. No definite CSF over there between the superior aspect of the pituitary gland and optic chiasm. And when you check on the midbrain and pons angle, there is decreased degree of the midbrain and pons angle. And when you check on the vessels, like in the vein of Galen and straight sinus and also superior sagittal sinus, it look a little bit distant or big engorgement. So this patient turned out to be like an intracranial hypotension, which is like a CSF leak somewhere. And then that why patient has like a sagging brain and lost a CSF space in the brain. And the dural sinus trying to take the space by engorgement or increasing in size. The key message here is don't miss the diagnosis for the Chiari-1 malformation, because if you check only at the craniocervical junction, you can see low lying or maybe crowding at the foramen magnum. But it's not the Chiari-1 malformation because you see that you lost the CSF space in other area. So this patient comes with headache, but there is a special described on the headache, which is getting worse when patient on the upright position and feeling better when patient lie down because no gravity that cause more CSF leak. So this is a patient that I just got a couple weeks ago, 18 years old, with history of liver transplant, and right now come with a visual change. So the Riley techs call me for scan check. The first one I did check on the sagittal T1, draw the line over there. I don't see any low lying of the cerebellar tonsils, but when I look up at the prepontine cistern, it's maybe a little bit flattening of the pons, anterior pons, and also decrease the CSF space in the suprasellar area. So I told them to give contrast, and on the post-contrast images, you can see diffuse dural thickening and enhancement along the dura, and maybe some engorgement of the dural venous sinus, but this one for the engorgement is not that significant. So this patient turned out to have like an intracranial hypotension. And when we check on the Cerner, patient has a history of lumbar puncture. So that's why we decide to do the myelogram, CT myelogram, and I have the images for you on the coronal image of the cervical spine and lumbar spine. For CT myelogram, we put the contrast in the thecal sac. So on the lumbar spine image, you can see that there is like a caudal equina nerve roots that show black signal here. On the CSF that have contrast that show bright signal. So there is a small air bubble here that related to the lumbar puncture that we give the contrast on the myelogram. But when you look closely, there is some leak of the CSF along the neural, like a nerve roots here, neural sleeve here. There is some leak here, maybe over there and also over there. And also on the cervical spine, it's maybe like a diverticulum or a small CSF leak. So this patient turned out that we do like a blood patch and patient's getting better. This is another patient. This is another patient with another diagnosis. So when you look on the sagittal T1 on this patient, this is a normal anatomy for you, for your reference. So this one, first thing that you can see here, there is abnormal shape of the pons. It's like a flattening and maybe some hypoplastic of the pons. you can confirm on the sagittal T2 that there is abnormal appearance of the pons. And then when you check more, the tectum looks normal, but there is something in the location of the midbrain that does not look normal. The midbrains trying to act or to make themselves itself like the tectum. So we call this thing tegmental cap midbrain. So this patient turned out to be like a pontine tegmental cap dysplasia. So abnormal findings of the pons and also the midbrain that trying to make itself look like the tectum. So on these axial images, I want to show you, if you look only on the axial image T1 or T2, you cannot see the appearance, the abnormal appearance of the pons very well. On this one, this is the midbrain area, pons amygdala. If you pay attention, yes, maybe you can call this is some abnormal, but it is really difficult. So, and when you look closely on the lower aspect of the medulla, you can see dorsal cleft of the lower pons and also short cerebellar peduncle. So I think the sagittal T1 for the abnormal findings of the midbrain, pons and medulla, we can see that things better on the sagittal more than the axial image. This is another patient. So first thing when you check at the midbrain, pons and medulla, so I told you earlier that the height of the midbrain, pons and medulla should be 1, 2, and 1. And on this patient is 1, 1, 1. So which means there is something abnormal in the pons. It's maybe like some hypoplastic of the pons, right? And then when you check on the posterior fossa, there is a CSF, cystic space in the posterior fossa that connect to the fourth ventricle. And when you look closely, there is maybe some hypoplastic of the cerebellar vermis. How can you know this is maybe something abnormal with the cerebellar vermis? So you need to check at the fastigium. We can talk more on the checklist on the posterior fossa, but the normally fastigium should approximately 50% of the pons, not upwarded like this one. So this patient turned out to be has like some abnormal of the pons and cerebellar vermis. So we call pontocerebellar hypoplasia. So the next step is the posterior fossa. Any questions for now? You still with me, right? So the third one is the posterior fossa. So there are a couple anatomy that we need to check. First thing is the primary fissure on the posterior fossa, and then you see the prepyramidal fissure. That is a fissure to separate lobule of the cerebellar hemisphere. So by these two fissures, we separate the cerebellar hemisphere as an anterior lobe 1/3 and posterior lobe 2/3. And then you have the small area that we call cerebellar tonsils. This is most important structure. Everyone at IU should know about this structure. This is the obex, right? And that is a fastigium, which is the apex of the fourth ventricle. So first thing, you draw the line at the posterior aspect of the midbrain and pons. You draw another line perpendicular to the first line, and this yellow line should be divide the pons 50 and 50%. So by this way, you can see that fastigium just above that yellow line. That is a normal position of the fastigium. And then if you draw another line at the fastigium and perpendicular to the red line, that's gonna separate or divide the posterior fossa or the cerebellar hemisphere like 48% and 52%. The easiest way to remember is like a 50-50. So in terms of the posterior fossa malformation, the couple things that you need to check is the position of the tacula hilophyllae and tentorium cerebelli to decide if the posterior fossa that looks normal size posterior fossa, big or small posterior fossa. That is the main thing. So on the first patient, you can see the elevation of the tacula hilophyllae. So this is a big posterior fossa. This is normal posterior fossa. And the third one is small because it's like a more stiff angle of the tacula hilophyllae and then the tentorium cerebelli. There is a good YouTube channel that gives you a very good review on the posterior fossa malformation that you can check. This is one of the very good YouTube channel that you can see the familiar face here. So start with this patient for the posterior fossa things. So this patient has the big posterior fossa, right? And then the second thing that you can see here is the cystic space, cystic dilatation in the posterior fossa. And the third one is like some hypoplastic of the cerebellar vermis, right? So by these three things together, you can give the diagnosis of Dandy-Walker malformation. But to confirm that there is some abnormal on the vermis for sure is you need to check at the primary fissure, secondary prepyramidal fissure, and you try to find the fastigium. So this one is totally abnormal of the fastigium that upward and anteriorly, superiorly displaced. So this is a Dandy-Walker malformation, which when you see Dandy-Walker malformation, there is usually some associated findings of the corpus callosal dysgenesis or some encephalosis or polymicrogyria or heterotropia. About this patient. So this patient, first thing that you can see here is patient has a very big posterior fossa for sure, with the cystic space in the posterior fossa and also hypoplastic of the cerebellar hemisphere. But on top of that, there is the defect, bony defect in the occipital bones and has the CSF containing lesions that connect with the intracranial, with the CSF in the intracranial. So in this patient, it's also Dandy-Walker because you have the full criteria of the big posterior fossa, cerebellar hypoplasia, and cystic space, right? But there is on top of that, this patient has a meningocele on the posterior in the occipital area. So there is some terminology that we use for a long time that we call like a Dandy-Walker variance or Dandy-Walker complex or Dandy-Walker spectrum. So we are trying not to use this word anymore because it's a confusion term. So when you want to say something Dandy-Walker, it needs to be like a strict criteria. If there is just some finding that relatively or like a look similar to Dandy-Walker, but maybe just a hypoplastic of the cerebellar vermis with the normal posterior fossa, we just describe those findings. We don't call Dandy-Walker variant. So try not to use that word anymore. How about this patient? This is another patient with the normal size of the posterior fossa. Here you draw the line there, right? And then you see some cystic space in the posterior fossa that connect to the fourth ventricle. Vermian hypoplasia, maybe because when you check here, there is some like a upward of the fastigium and some mass effect to the cerebellar vermis. So you check on the pyramidal fissure, prepyramidal fissure, and you see the fastigium upwards. So, and you draw the line, the fastigium just above that, the 50% line of the pons. So this patient turned out to be just an inferior Vermian hypoplasia. So this is a comparison on two patients that I just show recently on the pontocerebellar hypoplasia and inferior Vermian hypoplasia. So on the first patient, you can see here there is hypoplastic of the pons when you do the measurement on the height. Midbrain, pons, and amygdala is 1:1:1, and also have the components of Vermian hypoplasia. Second patient, when you do the measurement of the height, midbrain, pons, and amygdala is 1, 2, and 1, but have the same finding of Vermian hypoplasia. So that's why you need to check at the size and height of the midbrain, pons, and amygdala every time. Another patient, normal posterior fossa. You see the fourth ventricle that looks normal, right? And then you see some CSF space posteriorly to the inferior cerebellum. And you confirm on the coronal image that the cerebellar hemisphere looks totally normal. And there is no significant mass effect on that CSF space with the inferior vermis at all. And you confirm that things on the fastigium, that fastigium still in the normal position, right? So this patient has a CSF space, posterior retrocerebellar area, no mass effect at all to the adjacent brain parenchyma. So this one is the cisterna magna. So normally we do the measurement on the mid-sagittal image. If it's bigger than 10 millimeter with no mass effect at all, we call cisterna magna. This is another patient, normal posterior fossa here, normal fourth ventricle, normal cerebellar vermis, right? But you see something as a, okay, here. So you check on the fastigium. Is this a normal position of the fastigium, right? And then you check there is some like a cystic space posterior to the posterior fossa and also has some mass effect to the adjacent brain parenchyma and also some mass effect as like a scalloping of the inner cavarium. So this is arachnoid cyst. It's posterior fossa cystic stuff with a mild mass effect to the adjacent brain parenchyma. This is another patient, posterior fossa something, right? There is a normal size of the posterior fossa, but you also see some cystic dilatation of the fourth ventricles here, enlarged fourth ventricle and hypoplastic of the cerebellar vermis here. And first thing that you can see here is the cut your eye is like a very big ventricle, right? Patient has ventriculomegaly, super big ventricle. And when you are trying to check if there is something abnormal for the cerebellar vermis, you can see the upwards of the fastigium. So this is one thing that we see, I mean, like a once or twice a month. Patient has like a cystic dilatation of the posterior fossa and cause obstruction. So this is a brake pouch cyst, which is failed to fenestration of the brake pouch and cause an obstruction at the fourth ventricle. So that's why patient has a hydrocephalus. So this is 9 diagnosis already. Another patient, small posterior fossa here, right, on the sagittal T1 image. And then you see the tectum, that is a tectum, that is some tectal beaking that you can see here. Also flattening or maybe some hypoplastic of the pons and also small cerebellar hemisphere here. And when you check at the corpus callosum, there is very thin and incompletely form of the corpus callosum. So there is some dysgenesis or hypogenesis of the corpus callosum. Also absent of the septum pellucidum. So this patient is a Chiari 2 malformation, which is a neural tube defect and has an open spinal dysraphism, usually happen in the lumbosacral spine. And that's why there is continuous CSF leak and pull everything down. That's why we see these brain findings. How about this patient? Another patient for the small posterior fossa. You can see like a downward displacement of the cerebellar tonsils going to the foramen magnum and also kinking of the tectum and also upper cervical spinal cord here. And then you see a defect in the occipital bone contained with the CSF and also brain tissue. So it's large occipital encephalocele and there is some hemorrhage. And when you see this finding, normally you need to verify if there is herniation of the dural venous sinus on this one or not. But I mean, in this study, I did not show you. So there is some herniation of the transverse sinus within the encephalocele, within the CSF sac. So this is a Chiari 3 malformation. The easiest way to remember for Chiari 3 malformation that you have the findings in the brain for Chiari 2 malformation, but that myelomeningocele is usually happened in the occipital area or maybe like just the upper cervical spine. So it's finding of Chiari 2 with occipital or cervical meningoencephaloceles. For the first step, so only three steps, we got 10 diagnoses already. And going forward to the fourth step on the pituitary gland and pituitary stalk and also hypothalamus. So go back to our normal image on the sagittal T1 at the pituitary gland and stalk level. First thing that you need to remember or understand the development of the pituitary gland. So the pituitary gland has two components. The first one is the anterior gland, and the second one is the posterior pituitary gland that usually show T1 shortening or bright signal. So that bright signal comes from the hormone from the hypothalamus, like oxytocin or ADH that produced from hypothalamus and then pass through the pituitary stalk and storage in the pituitary gland. In terms of the development, the hypothalamus and pituitary stalk develop from base of the brain or diencephalons, while the anterior gland come from the reflex pouch. So both of them come and sit together in the stellar area. And that's why there is some potential space between anterior and posterior pituitary gland. Normally, you should not see anything, but sometimes you can see fluid between that potential space. In terms of the size of the pituitary gland, it varies, depend on gender and age group. So in children, when we do the measurement in the cranial caudal height, it's about like a 5 to 6 millimeter. In male or postmenopausal female, it's 8 millimeter. Young female during like a teenage period, it's like a 10 to 12. And in the pregnant woman or lactating female, it's like a 12 to 14. So it can be juicy. The easiest way to remember is there are two periods that you can see very prominent pituitary gland. First one is in the newborn period because there is a maternal hormone that can affect the pituitary gland. And also during the puberty period that you can see like a more juicy of the pituitary glands. So look on this patient. As we know that development of the posterior gland and hypothalamus and the pituitary stalk come from the diencephalons and anterior gland come from the reflex pouch. So this is a sagittal T1 in the stellar area. You expect to see some bright signal in the posterior aspect of the stellar. And when you don't see it over there, you need to check along the pituitary stalk if you can see something over there. So in this patient, you can see there is a bright signal of the posterior gland in the pituitary stalk. So when you see that thing, you need to check for any other associated finding for septal-optic dysplasia. In this patient, it isolated ectopic posterior pituitary gland. This is another patient, sagittal T1 image. This is a stellar area. You don't see the posterior pituitary gland in the stellar area. You check along the pituitary stalk. There is nothing on the pituitary stalk. And then you see some T1 shortening foci in the hypothalamus. So this is an ectopic posterior pituitary gland, right? And then you check on the axial image. There is absence of the septum pellucidum. So when you have that abnormal ectopic location of the posterior gland, absent septum pellucidum, you need to think about septal-optic dysplasia. And when you check the optic nerve, there is hypoplastic of the optic nerve. And then there is additional findings here, which is a cleft, CSF cleft between the ventricle extend to the subarachnoid space, and that cleft lining with a gray matter. So this is a schistocephaly. So this patient has a septal-optic dysplasia. So that's why I said sagittal T1 is quite important because when you see some ectopic location of the posterior gland, you need to check for any other associated findings to give the diagnosis. And then the next thing that we are going to talk about is the pituitary stalk. So normal appearance of the pituitary stalk should taper down from the tuberous cinerarium down to the pituitary glands. And it should not be bigger than 2 millimeter thickness. When you see the thickening pituitary stalk, here, this is the first image, is sagittal T1, absent of the posterior pituitary gland, right? And then when you see absent posterior gland, you check back, there is nothing along the stalk and nothing at the hypothalamus. And then you check on the size of the pituitary stalk, it's too thick. It's bigger than 2 millimeter on the post-contrast images over there. So it's come to the differential diagnosis when you see the thickening pituitary stalk. So in pediatric age group, when you see thickening pituitary stalk, you're thinking about the Langerhans cell histiocytosis. But for adult, when you see something weird, you're thinking about lymphoma. In children, it can be germinoma, which is tumor, high-grade tumor, or in adult, it can be metastasis. Or it can be some inflammation like a pituitary hypophysitis, or in adult, it can be neurosarcoidosis. So this is like a group of the differential diagnosis based on age group for thickening pituitary stalk. I want to show you this patient. So this patient come to the clinic with diabetes insipidus. We have the scan sagittal T1 image, absent of the posterior pituitary gland. We don't see any ectopic location of the posterior gland. And then we see the thickening of the pituitary stalk on the zoom up image here. The post contrast is definitely thickening, too thick of the pituitary stalk, and also have some abnormal contrast enhancement of the anterior and posterior glands over there. And when you look closely, there is some abnormal contrast enhancement in the pineal gland. The pineal gland looks too big and has some heterogeneous contrast enhancement. So this patient turned out to be germinoma. So when we think about germinoma, I normally think germinoma as a midline tumor that usually happen in the pituitary stalk or sella area, and then in the pineal gland. That are two most common locations for CNS germinoma. And then in children, when the patients come with the anterior mediastinal mass, germinoma is one of the differential diagnoses for anterior mediastinal mass in children. And when you go down to the testicle, it's also the midline things. Go to the testicle, for the testicular tumor, it's still germinoma. So germinoma to me is a midline tumor that can happen in the pituitary stalk, sella, and pineal regions. So almost always check in these two locations. If you see something abnormal in pineal, check sella. If you see something abnormal in sella, check on the pineal. Another patient come with DI. This is only 3 years old. So absent posterior bright spot, thickening of the anterior glands. So this patient turned out to be LCH. They did some like a workup and turned out to be like a Langerhans cell histocytosis. It's like a similar appearance, but there is nothing in the pineal gland. So that's why I want to say like it's almost always like a differential diagnosis for the thickening pituitary stalk. Another patient come with delayed puberty, 10 years old. You see the posterior gland here, but anterior gland looks relatively small. So I think at least the cranial caudal height here should be maybe like a 5 or 6, 7 millimeter, but this one look relatively small. So every time when you see relatively small anterior pituitary glands, the next thing, and if the patient come with the delayed puberty, the next thing is you need to check on the olfactory bulb, because there is one disease that patient come with delayed puberty and absent of the olfactory bulbs. That is Kallman syndrome. So this is one thing that you need to almost always checking on the olfactory bulbs. Like this patient, this is normal patient that you can see olfactory bulbs very, very well on the coronal image here. This is another patient come with headache. So on this one, first thing that you can see here at the foramen magnum, it looks normal, but when you check on the sella, there is a CSF field in the sella area that we call partially empty sella, which should not happen in teenage group, right? And every time when you see partially empty sella, it means some like a high pressure that happened. So you need to check at the optic disc. And in this patient, you see papillary edema, protrusion of the optic disc to the posterior group and prominence of the optic nerve sheath. So this is intracranial hypertension or pseudotumor cerebri. This is another patient for the step 4 checklist. So you have the sagittal T1 image here, absent of the posterior gland. Anterior gland looks probably okay. You check at the pituitary stalk. You don't see any ectopic location of the posterior gland, but there is something like a soft tissue lesion in the hypothalamus. No contrast enhancement. And you can also see those things on the T2 image, relatively T2 bright. So this one is like a bird eating something, have some food in their mouth. So this is a hypothalamic hematoma, which is non-neoplastic gray matter. And patient usually presented with 50% of gelastic seizure and 50% of precocious puberty. So the first thing that you see here is no posterior gland. That's why you need to check further. This is a couple more patients about the checklist on the anterior and posterior gland. As I mentioned earlier, there is some potential space between anterior and posterior gland that sometimes you can see the CSF in there. So I mean, in this one, you can see the CSF between anterior and posterior gland confined in the gland itself. This is para-intermediate cyst. Compare with another patient that you see CSF density and has some contrast enhancement and upward border over there. So this one turned out to be Refke-Krepf cyst. It's also some cystic in the anterior, can be like a between anterior and posterior gland, but you have some cross-eye or anterior gland enhancement superiorly. So this is a comparison for the para-intermediate cyst and Refke-Krepf cyst. So para-intermediate cyst confined in the sella between anterior and posterior gland, but Refke-Krepf cyst can extend to the suprasellar and has some enhancement of the anterior gland, anteriorly and superiorly of the cystic lesion. Almost done for the anterior and posterior glands. Are you still with me? Any questions, comment for now? So we can move.
Yes.
Can move to the next diagnosis. This is quite classic. So on the sagittal T1 image, you don't see the posterior gland very well, and you cannot see the anterior gland very well. There is also something in the suprasellar area that have some cystic and solid component. On the post-contrast images, you can see the cystic component and enhancing solid component. And on the CT, you can see calcifications. So this is quite classic for craniopharyngioma, which is a mixed cystic solid lesion with calcification in the suprasellar area. Yeah, we almost done. This is step 5 already, but we have many things to talk about on the step 5. We halfway through. So step 5 is the pineal gland, tectum, and cerebral aqueduct. Sagittal T1, the anatomical landmark image first, again, midline cut. There is a couple anatomies that I want to point it to you. So for the pineal gland, that is the gland that just above the tectum, and anterior to the tectum is cerebral aqueduct. That is a correspond image between the gross anatomy and also the sagittal T1, right? So we know that pineal is a third eye that has like a photosensitive and photoreceptor. We almost always talk about calcification of the pineal gland to help differentiate some kind of tumor that happen in the pineal region. So, but keep in mind that calcification of the pineal glands, we can see majority in older patients, right? But the pineal can start calcification as young as 2 years old. So if we have the pineal mass in the patient less than 2 years old, we cannot use calcification like an explode calcification or engulf calcification to help us differentiate the tumor. So looks on the normal anatomy in this patient. So pineal region over there, right? Normal pineal gland. There is a couple anatomy for you to checklist. First thing, this is a T2 image, and this is T1. There is a vessel, one vessel of furroid over there. That is an internal cerebral vein. So pineal gland usually almost always sit underneath the internal cerebral veins and also underneath the vein of Galen, right? And on these images, you can see the flow signal through the cerebral aqueduct that show this is patent cerebral aqueduct. This patient, the first thing that you can see here, teenage patient, why? Patient has partially empty sella. It's like a CSF in the sella area. So when patient has a partially empty sella, you need to think about maybe some increased pressure that happened in the brain or maybe some kind of obstruction. And then when you check at the pineal gland, pineal regions, there is some cystic stuff in the pineal area that show peripheral contrast enhancement. How can you know this is a pineal cyst or like a pineal in origin something? because you can see the vein of Galen and internal cerebral veins, and that cystic lesion just underneath the internal cerebral veins. And then we need to check every time when you see pineal lesions or pineal cyst, you need to check for patency of the cerebral aqueduct. So normally at Riley, we do the sagittal T2 3D space, and we use the flow signal or flow artifacts of that things to call obstruction or effacement. So on this patient, you can see that pineal cyst very well here, and also some effacement of the flow of the dark signal underneath the cerebral aqueduct. So that's why patient has a pineal cyst that cause mass effect to the tectum and maybe some obstruction at the cerebral aqueduct. So that's why we see the finding of the partially empty sella, increased intracranial pressure. This here. So in this patient, I have T1 post-contrast for you that you can see there is an enhancing lesion in the pineal gland underneath the internal cerebral veins and vein of Galen. And on the DWI, it shows restricted diffusion. So every time when we have something restricted diffusion, it can be acute stroke, right? Or it can be like a high-grade tumor, because high cellularity tumor or like a packed dense cells, you can see reduced diffusion or restricted diffusion. In pineal region, as we talked earlier, if you see something in the pineal, you need to check at the suprasellar area, and the pineal is one of the most common tumor, midline tumor for germinoma. So this one turned out to be germinoma, pineal germinoma, which is like a 50 to 65%, and suprasellar has 20 to 35%. But for neuroradiology fellows, the third most common location for CNS germinoma is in the basal ganglia. It's only like a 5 to 10%, but you still need to remember those things. And when you see something you suspicious for germinoma, we should get a complete evaluation of the spine for drug metastasis. Another patient, so this is relatively young patient. Sagittal T1 in the pineal area, there is some soft tissue lesion, show heterogeneous, some contrast enhancement, and maybe extend to the cerebral aqueduct, maybe some obstruction that you can see bowing of the corpus callosum. On the ADC image, it shows decreased signal here. So this means some high cellularity tumor, but in very young patient. So this turned out to be like a pinealoblastoma. So, I mean, if you don't tell me the age group of this patient, it's going to be very difficult to call this is germinoma or pinealoblastoma, but which age group, this is very helpful. So this is another patient, macrocephaly, 18 months old boy, macrocephaly. First thing that you can see here, big ventricle. Stretching of the corpus callosum. Fourth ventricle looks a little bit big, right? And maybe some like a CSF space inferiorly. But when you check on the midline structure, midbrain, pons, and medulla, probably okay. But in the tectum, the tectum is too thick and cause the effacement of the cerebral aqueduct, right? So in this patient, the tectum is too thick and has an obstruction at the cerebral aqueducts. This turned out to be tectoplate glioma, and we can see this one in an F1 patient. And when we do the flow signal T2 3D space, there is no flow at all at the cerebral aqueduct. So that's why patient has an obstructive hydrocephalus. Another patient, headache, cerebral aqueductal stenosis, concerning for aqueductal stenosis, big ventricle, right? Check at the tectum. Tectum looks normal. Cerebral aqueduct, it may be difficult to check on that things, but you can see the patient has some big ventricle to start with. So that's why we can add the sagittal T2 3D space, and there is no flow through that cerebral aqueduct. So this turned out to be aqueductal stenosis. So the last step for the checklist is the corpus callosum. So this is a very big topic for the corpus callosum. In terms of the development of corpus callosum, we usually talk about like, oh, it's starting from genu, splenium body, splenium, and rostrum, right? However, the development right now is not just like in these directions. It's normally like a bidirectional development. However, for the radiographic development, it's still, we can see the genu first, and then body, and then splenium, and then rostrum. And there is a couple more anatomy to point to you. The fifth one is the anterior commissure, and then hippocampal commissure, and also posterior commissure. So even like the growth is not the anterior to posterior anymore, but for the radiographic, we still need to remember it's starting from the genu body, splenium, and then come back to rostrum. And the corpus callosum development starting from 6 to 8 gestational age, and final shape at the 20 week, and continued growth and myelination, and has a target of full thickness at age of 7 to 9 years old. So when you see abnormal of the corpus callosum, you need to check for any other associated anomaly, because there is like a variety of associated syndrome, more than like a 200 syndrome that associated with corpus callosum anomaly, which can be genetic or sporadic or for chromosomal anomaly. If you don't see any corpus callosum at all, complete agenesis. Or if you see partial agenesis or hypogenesis or missing some part of the corpus callosum. So in this patient on the sagittal T1 image, the thing that you can see here is like a complete absence or total agenesis of the corpus callosum, that you can see like a radial or spoke wheel like appearance of the corpus, of the location that used to have the corpus callosum, or you can see like a Texas Longhorn side, or parallel or colpocephalic appearance of the ventricle. So this is the total agenesis of the corpus callosum. How about this patient? We see some part of the corpus callosum here, but there is some missing of the posterior, of the splenium, and maybe missing of the rostrum of the corpus callosum. Posterior pituitary gland looks normal, right? So when you see some abnormal, like a hypogenesis of the corpus callosum, you need to check for any other associated findings for the optic nerve, septo-optic dysplasia, or cavum septum pellucidum. So this has a corpus callosum hypogenesis. Another patient. So sagittal T1, maybe small posterior fossa, a small posterior pituitary bright spot over there. But when you check on the corpus callosum, you see the posterior aspect. You see splenium of the corpus callosum, but we're missing the anterior, right? We don't see the body, we don't see the genu, and we don't see the rostrum. But in terms of the development, if something bad happened, the first missing part usually happens for the rostrum, and then you're missing the splenium, body, and genu, right? But this one, it does not follow the rules. You're missing the anterior part, including the rostrum, but you have the splenium present. So this is quite characteristic for holoprosencephaly. And you also see absence of the septum pellucidum and also single monoventricle. Okay, so that's all 30 diagnoses that I have for you today. But we're gonna start more like an interactive thing since we have trainee here. I have total of 8 cases, 8 questions for you. Who want to do first? I think we have 4 fellows, right? Joining us here. 2, yes, okay. So first one, who want to take this one? Teenage boy, not a teenager with headache. Who want to take this one?
Dr. Supakul, I can take this. This is Stephen.
Yes, sure. Stephen, thank you. Mm-hmm.
So we have looks like a T1 sagittal. Actually, they're all T1 sagittal, and then, yeah, all T1 sagittal images.
Mm-hmm.
So let's see, which patient needs surgical intervention? Well, the first one, looking at the pituitary, looks like a normal pituitary bright spot in expected position. So normal patient. B, looks like the tonsils are a little bit, maybe there may be tonsillar ectopia. But nothing too concerning. The C, though, looks like we have an expanded sella, partially empty sella. Looks like maybe the tonsils are a little down. Looks like that pre-pontine cistern is effaced. So I think C would be the answer.
So what do you think for the patient's A?
I think
Diagnosis for
that
patient A?
I think there's some intracranial hypertension.
Are you talking about patients A or patient C for the intracranial hypertension? So C is intracranial hypertension. How about B?
That one looks like hypotension.
Hypotension, right? Some crowding here, but you have like an effacement of the CSF over there. How about patient 1? What is the diagnosis?
That is Chiari malformation.
Chiari 1 malformation. So patient who need a surgical intervention for decompression is patient number 1, right? To have like a craniectomy and laminectomy to open at the craniocervical junction. Thank you so much, Stephen.
Tanya, can I ask a question?
Yes, sure.
How often do you see signs of intracranial hypertension in long-standing Chiari-1 malformation that has not been surgically repaired?
But I mean, once in a while we see that things too, but somehow I think Chiari-1 malformation is something that come and goes. Sometimes you see it, sometimes you see it, but I think it's just like a development of the brain and bone that does not go together very well. Yeah, but for the obstruction and like those things, I don't see it that often, but we can see some once in a while if it acute.
All right, thanks.
Want to take this one for patient. The question is prenatal folic supplement may be helpful in which patient? To take this one, fellows. Paul, you are on Riley, so you are willing to take this one too.
Sure, I can take it. Can you hear me?
Yes, I can hear you.
Okay. C looks like Dandy Walker malformation. I can't remember if that one's associated with poor folic acid, but that one seems the most severe. I'm going to go with C.
You say it again.
Oh, and this is in which patient? Okay. What was that?
So which means first step.
The folic acid looks like Dan.
Yes. The first step is you need to give the diagnosis for each patient first. And then you know which one need the folic acid supplement, which means like the one that has the diagnosis of a neural tube defect.
Oh, right. Okay.
Because a neural tube defect need the folic acid supplement. So you need to give the diagnosis for each patient first.
So A looks like an arachnoid cyst back there. C looks like Dandy Walker.
Yes.
And D. And then D looks like a Chiari. So Chiari 2 is what's going to need the supplement.
Yes. So the answer is D, right? So the patient's number 1.
Yeah, can you hear me?
Yes, I can hear you. Okay. You want to say again, Paul?
Yes, I'm switching audio. Can you hear me better now?
Yes, I can hear you better.
Sorry, I had poor connection. I was talking. Sorry, A is Blake pouch. Yep. B is going to be your arachnoid cyst. C is Dandy Walker. D is going to be your Chiari 2, and that's the one that needs the folate.
Yes, correct. Right. Correct. So the first one has a hydrocephalus, cystic lesions, posterior fossa, obstruction at the fourth ventricle, and has a hydrocephalus, so break pouch. Second one, normal posterior fossa, cystic lesion, minimal mass effect to the tacula, arachnoid cyst. The third one, big posterior fossa, hypoplastic of the vermis, cystic space, right? Dandy Walker. And the patient D, hypogenesis of the corpus callosum, small posterior fossa, low lying of the cerebellar tonsils, right? And tectal beaking. So Chiari tumor formation need a folic acid supplement. Next. Yes. Can you take this one for me, please?
Sure. Can you hear me?
Yes, I can hear you.
So looks like you have a sagittal T1 weighted sequence with mass effect at the superior aspect of the tectal plate, additional mass effect or mass basically filling the hypothalamus and along the inner surface of the genu, the corpus callosum. Let's see. There's kind of mixed signal within the mass, so some increased signal that suggests, either fat or blood products.
This is a post-contrastive method.
Okay. So then it's presumably enhancement. Just off this picture, I would have to say, it may be solid or cystic and solid with some enhancing components. So in a 15-year-old, I'd wonder about, craniopharyngioma or, less likely like a germinoma, just off this picture. I
think it's unfair because I did not give you the DWI image. But if I give you the DWI image and it shows restricted diffusion, what do you think it is?
Yeah, I would say a germinoma.
Right. So which means when you see lesions in the pineal and also in the suprasellar area, we need to check on the DWI. And if it shows restricted diffusion or something, it should be high-grade tumor, and germinoma is the most common midline tumor. Like a pineal, like a two locations together, right? Pineal and suprasellar. Job. Yep, this is our questions number 4. Who else do I have here? And do you mind to take this one for me?
Sure. So starting with the image on the left, I think the posterior fossa looks like it's a little bit small. I think that the vermis positioning of the fastigium and the fissures looks like okay. Ovex looks okay. I'm looking in the kind of the region of the solaturcica, and I don't really see the pituitary gland, either the anterior portion or the posterior pituitary bright spot.
That's fair.
And then I don't know, it just seems maybe there's a little bit of prominence of the third ventricle. I don't know. And maybe. Sorry, go ahead.
No. I think that's fair because you cannot see the anterior and posterior gland very well. So every time when you don't see that things very well, it's maybe absent of the posterior bright spot. So what next that you need to check for?
Try to follow and see if we can see a component along the infundibulum or hypothalamus, which at least on this image I don't really see.
Yes. And what else do you see on the axial T2? Or you don't see on the axial T2?
Is this all one patient or is it 4 separate?
This is one patient.
Oh,
One
okay.
patient, yes.
Gotcha. I don't see any evidence of the septum pellucidum. And then the third image, it looks like it's very like hypoplastic optic nerves.
Yes.
And then if I look then on the coronal image, it looks like the we do see the optic nerves present in the fossa. So given this constellation of findings, we're very firm for like septo-optic dysplasia.
Yes, yes. So this is like an absence of the posterior fossa, posterior bright spot, absence of the septum pellucidum, hypoplastic of the optic nerve. I'm just trying to show you that we see bilateral olfactory bulbs. Okay, so this is a septo-optic dysplasia. Okay, questions number 5. Do we have Tony here? See. Okay. So who can take this one?
I can try to take this one. This is Carlos.
Thank you so much, Carlos.
So we have 2 sagittal T1 images, and we have posterior fossa, myelomeningocele. Kind of looking at the vermis as well. Looks like it's hypoplastic. It's elevated a little bit, especially in the pons also looks hypoplastic as well. It's abnormal in appearance. The midbrain as well is abnormal in appearance.
You're talking on the patient's number 1, right? Or
yeah,
number 2?
It's patient
number
number
1.
Okay, yeah, patient number 1. Okay, so just to be clear, patient number 1 is only a cephalocele because we don't see any herniation of the brain content. So it's a cephalocele.
Yes. Okay.
So I think this the first case would be maybe a Chiari 2 malformation, I would say.
The first one, the first patient, you think about
Yes.
the Chiari 2?
Yes.
So let's step back a little bit.
Okay.
So for first thing, when you see some cystic stuff in the posterior fossa or something abnormal in the posterior fossa, we need to define if this is like a big posterior fossa, normal posterior fossa, or small posterior fossa.
Okay. So this would be a big posterior fossa.
Yes, correct, right? And there is only one disease that patient has a big posterior fossa that we almost already talking about. That would be Dandy Walker. Dandy Walker, right? And
Right,
then you
right.
so this is a big posterior fossa, elevation of the tocula, cystic space, and then you see like maybe some hypoplastic of the vermis or cerebellar hemisphere, right, on the first patient. And then this one, Dandy Walker, with something that you already mentioned. With the Yes, right.
Cephalocele, yep.
Yes. How about the second patient?
So the second patient, again, we have a T1 sagittal T1 weighted image. In the posterior fossa, again, we can see there is a occipital defect with herniation of brain and CSF contents. This would be encephalocele and myelomeningocele. The brainstem itself looks abnormal as well. We have, the midbrain, the pons, they look abnormal. Posterior fossa also is maybe small, I would say.
Okay, good.
So I think this is probably, and then we can see there is kind of kinking of the upper cervical spinal cord there at the craniocervical junction, a little bit below the craniocervical junction. And I think, if I could recall this case, it was Chiari 3 malformation.
Yes, that's correct. Good job.
Yeah.
Good job. Yes. So patient number 2 is like a small posterior fossa. When we see small posterior fossa, we need to think about Chiari malformation, right? Chiari is like can be like a Chiari 2 or Chiari 3. Chiari 1 has a separate entity unrelated to neural tube defect. 2 and 3 are related to neural tube defect. And Chiari 2 has some like a myelomeningocele at the lumbar, thoracolumbar, or sacrum, but Chiari 3 has that defect in the occipital or upper cervical spine, right? And you are correct. This is like a small posterior fossa with that myelomeningocele thing and has the findings in the brain that consistent with Chiari 2 malformation. So which means Chiari 3 malformation is a neural tube defect. And that's why we need, related to neural tube defect. Good job, Carlos. Number 6. Who want to take this one? The question is, the first step, you need to know what is the diagnosis based on this image, and then you will know what is the most common clinical presentation.
I can take this one again. This is Paul.
Yes, sure.
Looks like there's a kind of a T1 hypointense and slightly T2 hyperintense lesion within the hypothalamus. It looks like that could represent a hypothalamic hamartoma. And if that's the case, then the 2 most common clinical presentations would be precocious puberty and gelastic seizures.
Yes, good job. So that's why when you do the scan check in this patient, when you don't see the posterior bright spot here, and you check along the tract and you check on the hypothalamus, that's why you need to give contrast, right? To confirm there is like a no contrast enhancement in that lesions, and you can call hypothalamic hamartoma. Good job, Paul. Number 7, who do we have here? We have 2 more questions. Question 7, who want to take this one? Name the findings and most likely diagnosis. Wes, can you take this one from me, please?
Sure. So we have a sagittal T1 weighted sequence and then a sagittal T2 weighted sequence. The posterior fossa looks small. The midbrain pons and medulla look abnormal. The pons look small. The obex is kind of hard to see, but the fastigious doesn't look like it's in a normal place. I don't really see the primary fissure. It's hard to see really any of the fissures.
Agreed. It's unfair. I know I'm unfair to you.
It's okay. But I mean, I would probably say, I mean, the pons looks hypoplastic.
Agreed.
And there's the inferior vermis looks hypoplastic as well. And I mean, and then the medulocervical junction looks odd as well. It's kind of kinked.
Yes. About the midbrain?
It's also like kinked with the pons. Like it's not in a normal location either. It's down, inferiorly displaced.
That is the findings, right? Because the midbrain does not act like themselves as a midbrain. Midbrain trying to mimic the tectum, right? Make it like a cap, like a tegmental cap, and abnormal of the pons, right? So this one is let me show you. Yeah, this is a pontine tegmental cap dysplasia. So it's like a hypoplastic of the pons and the midbrain trying to mimic the tegtum, making like a cap or something to cover the pons. So it's like a pontine tegmental cap dysplasia.
Okay.
But you got the findings of the like abnormal of the pons and abnormal of the midbrain and maybe something abnormal for the posterior fossa. Yep, agree. Good job. Last one. Question number 8, last one. Who can help me take this one? Who want to take this one?
I can go ahead and take this, Dr. Supakul. This is Stephen.
Yes, thank you.
So let's see. We got sagittal T1, 2 coronal T1s, kind of through that posterior fossa.
Yes.
Looks like we have kind of a small pons midbrain, and it looks like we're missing the vermis almost. Looks like there's a communication of the fourth ventricle. And maybe that, yeah, the vermis is just small, I think, but there's a communication. Let's see. It looks like the posterior fossa is normal in size.
Yes.
So this would be consistent with a Blake pouch cyst, I believe.
Break pouch is usually cause obstruction, right?
So you're right. Okay.
Yes, hydrocephalus. But you mentioned something for the pons. Do you think
Pons
it's normal?
is very hypoplastic.
Okay. Like a hypoplastic of the pons, right? And some cystic stuff here, upward fastigium, and hypoplastic of the vermis. Okay. Good.
I'm sorry, I'm going blank here.
That's okay. So it's hypoplastic of the pons, cystic lesion in the posterior fossa, hypoplastic of the cerebellar vermis. Put two things together, pontocerebellar hypoplasia. That is the final diagnosis. You got our findings, Stephen. In summary, so this is one of my favorite sequence, and I usually encourage our trainee to check on the sagittal T1 because there are too many things that you can see on the sagittal T1 in terms of the midline structure, foramen magnum, any low lying of the tonsils, for the most common thing is like a patient with headache. You can differentiate between Chiari-1 malformation, intracranial hypotension or hypertensions. And you can also see some abnormal development like pontine tegmental cap dysplasia. And for the sella pituitary stalk, it's also like many things that you can see based on the sagittal T1. Also like a septo-optic dysplasia, ectopic of the posterior glands. For corpus callosum, I think this is the one that can alert you to check for other associated findings. And also the pineal cyst, tegtum, and cerebral aqueduct that can tell you for the pineal cyst or like a pineal tumor on the sagittal T1. And this is the big topic for the posterior fossa that I encourage you to watch the YouTube channel on Dr. Wu's YouTube channel. He has like a really good summary for the posterior fossa malformation. So in terms of the report, for the sagittal T1 things that we talked today, this is the report that I normally put in my dictation, that I'm talking about the posterior fossa, about the corpus callosum, about the posterior pituitary bright spot. I mentioned the anterior pituitary glands. I'm talking about midbrain, pons, medulla, also posterior fossa. And the olfactory bulbs is something that I normally check, and I consider it as a midline structure. I think that's it for me today. Any questions from you guys? And we have the evaluation form that I sent to the chat box. So please complete the evaluation form for us so we can know what can we do, what should we do to improve the quality of the lectures and program. Any questions from you guys, comments? I know that there is some like a technical difficulty for the audience overseas, right? That there is some like a lacking of the signal or something.
Yes, a little bit. In the Facebook and YouTube now, has no comment.
No comments. Okay. So if there is no comments or suggestions, so I mean, I send a link to you. So please complete the evaluation form for me. And for the participation, for the audience from Thailand. So please also, so whoever register for this course, we're gonna send an email to you. So please complete the evaluation form by Friday midnight. So by that way, when you complete the evaluation form, you will get the CME credit for watching participation in this lecture. And I think we will try to figure things out for the IT issue and in terms of the signal for next time. So the next session is going to be next month on the 4th week of August. And we are going to talk about some epilepsy things or something more genetic like mTOR and tubulinopathy by one of our famous speaker, Dr. Isaac Wu. So thank you so much, everyone, for joining us today. And thank you, Dr. Hibbert and Dr. Holland, and also Melissa from the Child Protective Team joining us today. Thank you, everyone. Bye-bye.
Thank you for the presentation ค่ะพี่ตาลค่ะก็สำหรับประเทศไทยนะคะขออนุญาตว่าก็จะต้องส่งตัวคนที่ลงทะเบียนนะคะจะต้องส่งตัวคอมเมนต์ใช่ไหมคะก่อนวันศุกร์เย็น